Connecting now. Hi, welcome everybody to the 2021, not 2001 Digital Health Series here at Healthcare Innovation. My name is Stephen McCollum. I'm the Director of Programming here, and I thank all of you for joining us, as well as I thank all of our panelists for joining us as well. Just a few quick housekeeping notes while you're here. You may notice, if you've been a past virtual event attendee, that we have a new platform. So if you have any questions, please make sure that you use the Q&A box that's at the bottom of the screen. It says Q&A and has two little chat bubbles above it. Make sure that you use that. Don't put your questions in the chat box itself because we may not see them. So if you do have questions for our panelists while you're here, please put those in the Q&A box, as I mentioned. We're going to have a quick introduction of our panelists in just a few minutes, and then we'll jump into our discussions. And if you need any technical assistance while you're here, please put that in the chat box. That's where I can help you out if you need technical assistance. All right, everyone, I'm going to go ahead and get our panelists introduced. First up, we have Dr. Jeffrey Lebenger, who's the Chief Executive Officer of Summit Medical Group and CityMD. Welcome, Dr. Lebenger. Thanks for joining us. We have Nick Loporcaro, who is the Chief Executive Officer of Landmark Health. Welcome, Nick. We also have Dr. Adam Solomon, the Chief Medical Officer of the Memorial Care Foundation. Adam is joining us from the West Coast, so it is very early for Adam. So Adam, thank you for getting up so early and joining us before the sun rises. And last but not least, we have Dr. Stephen Klasko, President and Chief Executive Officer of Thomas Jefferson University and Jefferson Health. Welcome, Dr. Klasko. And our conversation today is moderated by Mark Haglund. Mark, welcome. Welcome, panelists. And Mark, I will turn it over to you so we can get the panelists to share a little bit more about their backgrounds. And I'm going to step away, and I will see you guys when we get to the Q&A portion of the program. Thanks again for joining us today, and welcome, everyone.
Thank you so much, Stephen. Thank you to all of you in our audience for joining us. We're so excited. I've got a panel of amazing leaders with me. I'm very, very, very gratified and delighted that they agreed to join us and take time out of their very busy schedules. And again, a special shout out to Dr. Solomon for joining us even before the dawn breaks in California. So we really, really appreciate it. We're going to talk about some very broad topics right now. I want to do a level set, but first I'd like to ask each panelist to literally just spend 1 minute and describe their role and very, very briefly their organization and their connection to the topic of what's next in the next 24 months in US healthcare delivery, operations, and policy. I'm just going to kind of go visually by my little how my screen looks. Dr. Klasko, why don't you go first?
Sure. I'm the president and CEO of Thomas Jefferson University and Jefferson Health. Jefferson University is a 196-year-old academic medical center. It was actually the first medical college in the country that thought seeing humans was a good idea before you got your MD. Before us, you would do all your research and academics before you actually start to practice on patients. Over the last 5 years, we've had 6 mergers. We've grown into a 14 hospital system. We're fighting the FDC for another one. And we've also had a very interesting merger with our health science university and one of the top 5 design universities in the country around the design of the human experience. As it relates to COVID, we had by far the largest amount of COVID patients in the Philadelphia region, about number 20 in the country. We're very proud of the fact that we had among the lowest employee infectivity rates. And then finally, I think post-COVID, really, we went from an old math to a new math model. The old math being in-person tuition and heads in beds, hospital mentality, starting in 2013, to a new math of innovation and strategic partnerships along with those things, what we call healthcare at any address. So we were actually pretty well positioned for this post-pandemic world.
Wonderful. As I say, I'm just going visually by my screen. Dr. Solomon, why don't you go next and describe yourself and your...
Sure. Good morning, everyone. Well, through the course of the morning, you're going to start to see a little bit more light coming in and see me a little bit better. I think I've got a bit of shadow. So I'm the Chief Medical Officer of the Memorial Care Medical Foundation. In California, there's a law that hospital systems can't employ doctors, so they have this thing called a medical foundation, which has an agreement with physicians for them to provide services to the system. So I oversee our 300 provider medical group, along with our 150 primary care physician independent physicians association. We are a 4-hospital system, including the 10th largest freestanding pediatric hospital in the country. And our interest really has been in providing value to individuals as well as to populations. And so we have about 150,000 full risk lives that we manage through managed care, and then about another 100,000 lives that we are at risk for through PPO ACOs. We're also the preferred partner for Boeing. And these kind of partnerships allow the health system to really provide that full breadth of healthcare services to those organizations and to populations.
Wonderful. Thank you so much. And then Dr. LaBenger.
Yeah, hi, everybody. Hope everybody's well and safe. Summit City MD is the largest independent multi-specialty group in the country. We believe in patient attribution, and we're bringing it to the entire New York metropolitan area. We have been in risk for a long period of time at the group. We have 2 feet in 2 different canoes in the PPO world and the HMO world. And right now, everybody is striving to the value proposition, and we are learning through data analytics how to scale it and how to manage it really well in our population. As for COVID, it was unbelievable. The light switch went on for virtual visits. And interestingly enough, in the New York metropolitan area, we saw the most COVID visits. We saw 3.5 million visits for COVID through our urgent care business, our integrated healthcare business.
Wonderful. Thank you so much, Dr. LaBenger. And Nick Lopercaro.
Morning, Nick Lopercaro, CEO at Landmark Health. Been with the organization now almost 2.5 years. Spent the better part of the previous 16 years at McKesson. Landmark, in essence, takes care of very frail, polychronic, multi-morbid elderly individuals in home. We're a longitudinal, comprehensive care organization, have grown significantly. The organization's about 7 years old. Took us 5 years to get into 25 MSAs. The last 2 years got us into 50 MSAs. And I'm always careful on how I frame this, but the pandemic has truly shown a spotlight on what we do and why we do it. And that growth rate has accelerated even more so. Our model has primarily been focused on working with MA plans. We've seen that change with the pandemic as well. We now have large at-risk provider groups, health systems as partners. We're currently in 17 states and have close to 140,000 attributed lives.
Wonderful. Thank you so much, Nick. And again, thank you all for joining us today. So I'm going to plunge in. I'm going to try to do a little bit of a level set. And I first just have to tell a story from history because I love history. So some of you will remember Louis XVI and Marie Antoinette of France both lost their heads to the French Revolution. And there's this famous moment where the fishwives of Paris have stormed the gates of the palace. And Louis looks out the window and says, it seems to be a rebellion. And his courtier says, no, sire, it is a revolution. And so we don't really have fishwives with pikes and torches, but we certainly do have very impatient purchasers and payers in healthcare. And as I often like to cite, the Medicare actuaries are telling us that within 6 years, we will go from the current about 3.3 trillion a year in annual total US healthcare expenditures to 6 trillion, which should scare the pants off anyone and certainly is a burning platform for change. The question is how revolutionary we will be. I think what I'd like to do is throw it out to everyone, revolution or evolution, and focus on what do we think might happen in the next 2+ years around changes to delivery, operations, and payment. You're all involved in very advanced organizations. You're all either taking on risk or certainly are in value-based contracts, and you see the future. So who would like to leap in about how revolutionary the next couple of years will be.
I'll start. I think it depends on two factors. It depends on whether or not our policymakers develop some courage. In the past, we've just argued about how to give more people access to this fundamentally broken, fragmented, expensive, and inequitable healthcare system, and then congratulated ourselves. So it's just been different ways of, how can we expand Medicare? Can we expand Medicaid? At the end of the day, all of us on this panel know what the issue is. Everybody profits. Bernie Sanders was 100% right about the problem. The pandemic proved it, right? Health systems lost billions of dollars. Payers, because of the medical loss ratio mentality, made a lot of dollars. In other periods of time, healthcare providers have held payers hostage. We know that the paying pharma retail makes no sense. So we know the things that don't make sense. We know that paying dermatologists and neurosurgeons 15 times what we pay family doctors and then asking them to be the quarterbacks don't make sense. So one thing is, are we willing to really confront the root causes of what makes healthcare expensive? And then on the second side, on the consumer side, I think whether it's an evolution or a rebellion or a revolution is going to be dependent on whether or not consumers have their "I'm mad as hell and I'm not going to take it anymore" moment, right? I mean, I'm an obstetrician. I'm working with some companies that are doing remote patient monitoring for almost all non-stress tests. What's interesting is hospitals don't want that to happen because we make a lot of money from having people come in, and it's hard to get somebody to do something when their salary depends upon them not doing it. But 28-year-old people that don't view themselves as patients are saying, let me get this straight. You want me to come to the hospital 3 times a week, pay $35 to park, go to a place where there's a lot of sick people so somebody can put something and I can stare at the ceiling, or I could be at home watching Little Fires Everywhere and have somebody come on my iPad? I think I'll choose that option. So to me, those are the two variables that we have to see what happens post-pandemic.
Yeah, I know, Dr. LeBenger, you'll have something to say about that because your organization has done so well in risk and you've really care managed your population to the point where you are moving as much as possible upstream.
Yeah, so I do think, I break it down. I'm a concrete kid from Brooklyn, so I try to break it down, okay? So I do think fee-for-service claims adjudication is not going away, okay? Now, I know there's a governmental on MA and we're moving to direct contracting, but in most payer contracting is still based on, a fee-for-service world. And we have to look at that. So I don't think in the next 2 years, you're going to see much motion from that as you move, but you will see a move to value in this world. You're going to see at least the larger groups or hospital institutions, or as you can do an IPA, or as you get, a more of a clinical integrated model, they will be looking at how to measure risk, the risk of the patient, how to measure stars ratings, because what this will do, forget about being a physician and being altruistic and wanting to do the right thing for the patient and making the right model for the patient. You have to look at the medical economics of this world, and the margin is going to be compressed, and everybody's going to be looking at increasing that margin. And in a hospital, for good or bad, it's ancillary embedding. In the ambulatory in the world, we're moving to more of an ambulatory network to leave the high cost areas. So you have to juggle that and see where your model is taking you in this. And I feel for people who have fixed overhead, and a lot of fixed overhead in this world, and have to justify that. We don't. We're very nimble and we can move and we can adjust, in the organization. And I want to just put something else out. You're talking about margin compression of hospital systems and are working. CMS just came out with a rule change of changing 99213, 99214, and the conversion factors within it. Okay. That's Medicare. Commercial did not. Okay, so if you pay on $1 per RVU to doctors, I'm just going to throw it out there for everybody, is that what's going to happen is you're going to have to pay physicians more money for the amount of $1 per RVU, and it's going to press the margin on the other side. So there's a lot of things that are happening in this world right now that you have to think about how you're going to run risk in your organization, right? For us, it's always the clinical model, what you do right for the patient, how you partake in that care of that patient. That's where the best savings, are located.
Right. So, Dr. Solomon, let me throw this out to you because Dr. LeBenter has just shared a lot of really interesting points. Now, you're in Southern California where you've had experience with managed care and value-based contracting for many years. You're also affiliated with a large health system, but but as you mentioned, physicians have to kind of run their own shops in California, at least technically. How do you see it? Revolution, evolution, fishwives with picks uh, and torches, or maybe something gentler?
It might be employers with picks and torches and then a gradual evolution. Things in healthcare do not change dramatically unless something dramatic happens. And we saw that with COVID, and we had to pivot from in-office visits to virtual visits within just a few days. But then we've gradually seen that slow down. We were doing more than half of our visits virtually, and we're now at a point where we're between 14 and 22% of our visits are virtual. The patients have generally gone back and wanted to come into the office. The physicians are happy to do it either way, although sometimes they're not quite yet comfortable with virtual. But what I see is the same thing that's going on with other parts of our world right now, is this sub-segmentation. So people expect convenience if they're not using something regularly. And when I want to order out, I'm going to go on my app and order out. If I if I want to talk to my friend, I'll chat. I'll send a text to them, and they'll get back to me when I want. And I text them when I want. Healthcare is a cottage industry. It's been that way for so long, and even you still see so many of these little independent offices that are practicing on paper. Here we are in 2021.
Yeah.
And it's the same way as we practiced, decades ago. And even these large health systems that, we're now on this EMR and everything is new, but it's still, in general, people, they get sick, they come in, they get treated, or they go see somebody for an acute problem, they get managed, and then they leave. And I think there's a segment of the population that has these intermittent interactions with the health system. So if I'm generally younger, generally healthier, I don't need to be seen except I have a sinus infection or an ear bladder infection, something like that, or an injury. I want to go get seen conveniently. I don't want to leave my house. I don't want to have to call somebody and wait on hold. I don't want to sit in a waiting room. I just want to get the care that I need in the most convenient fashion for me. And then if you do it today, and then tomorrow you make me wait, I'll just go over here, because I don't really have loyalty. But I think there's a different segment of the population that they're starting to have a little bit more chronic disease, and they've struggled with the navigation of our really complex system. And there's a turning point when people want to have that attachment to an organization that's looking out for their chronic needs. And I think those two things need to be addressed.
Yeah.
But right now they're being addressed in pieces, and it's sub-fragmenting healthcare even more than it ever was.
Yeah, no, I completely agree, Dr. Solomon. And first of all, it's so interesting. Many of us have children. My daughter is 19. When she was younger, I had to explain that there was a world before smartphones, and she didn't actually believe me. So that's the millennials. And then I've had to explain to friends outside healthcare that people are still using the fax machine. Right. Like, I mean, in any other industry, they're like, fax? Like what? Like what? But I think you've pointed out something really important. Of course, now we all know there are younger people with chronic illnesses, but certainly there are more who are middle-aged and older. What I think is really interesting is how there's this pincer movement, because many employers have forced their employees into these high deductible plans. And that really is making consumers more sensitive to what they're getting and what they're paying themselves. And as you mentioned, I'm glad you referenced COVID. One of the things that we know that happened with COVID, it made people very aware as consumers of how the really basic mechanics of the healthcare system work, such as making an appointment, right? And how you connect with your physician and your physician's team and all that. I think there's a level of awareness among consumers that's really going to kind of change the equation over time. Plus, we're all living in the world, right? We're living in the Amazon world. We're living in the Grubhub world. And the level of inconvenience in healthcare that has been accepted until recently is not going to be so accepted going forward.
So Mark, let me give you an example. Again,
Yeah.
in my world of obstetrics. So when I was in private practice, what would happen is a woman might be late for her period. She would go to her 65-year-old male primary care doc who would do a pregnancy test, and he would say, predominantly he would say, "I'm going to send you to my obstetrician, Dr. Klasko." And she'd say, "Thank you very much, Dr. So-and-so. I will go there." The chances that a 26, 27-year-old person will go to a 65-year-old male primary care doc and then decide for the most important thing in their life to go where that person told them to go.
Right.
Now they'll say, well, that's very nice. And that might be who you'd go to if you ever got pregnant, which you won't. But I'm going to really talk to friends. I'm going to go on the internet, et cetera. So we actually started a match.com for obstetricians and patients. So that literally, I'm Mrs. Jones. I'm 25 years old. I live in Bryn Mawr, Pennsylvania. I'd like to find a doctor that will accept my doula, that can see me on Fridays because that's the only day I can get off. I have Aetna Gold. I don't want to spend more than $1,000 of my money. I want to know what patients say about you, what your C-section rate is, et cetera. What's interesting, Mark, is that when we talk to obstetricians around the country, 50% will say, you know what, that's it. I'm never practicing again. This is the end of medicine as we know it. The other 50% will say, that's really cool. Where do I sign up? There's a huge age and gender difference between A and B.
Yeah, absolutely. So,
Mark,
sure, yeah.
Before you get to Nick, and I'm sorry, Nick didn't talk, but one thing that COVID showed us that I think we have to think about is that, we were seeing 25,000 patients a day on urgent care, and we're seeing about 10, 11,000 on an integrated healthcare model. Okay. In one day, we flipped the switch and we went to virtual visits where we were doing 3,000 in-person visits to 7,000 to 8,000 virtual visits, literally in one day. And I think the first question that you asked, how is medicine going to change and what's going to happen, is that it's generational, right? We're going to have to look at the access to healthcare extremely differently between virtual urgent care and going to a primary care office. And I think that a lot of doctors on the outside are going to see that they could see a virtual visit for a UTI, a sinus infection, an ear infection, and not go to the office. And it's going to open up, I think, access to in-person care. I think that's one thing that will happen in the near future. I'm sorry, Nick.
That's okay. That makes sense. I agree with you also, Dr. LaBetra. So Nick, it is now your turn. Thank you so much for your patience. You're riding the wave of change, and your organization, from what you've shared with us, was organized based on where the healthcare system is going. You were skating to where the puck was to begin with. How do you see this whole change question?
Mark, I don't know if your puck analogy was intentional, as I'm a Canadian and you use one of my countrymen's references here. Well, look, I've got the opportunity to try to unpack my three colleagues here's comments. I want to touch on something Stephen said first, and then get to your question about is it an evolution or revolution? I think when you think about the system, right? The reality is, and I use this hokey analogy of the patient, the payer, and the investor. And I always say the patients need everything you can give them. The payers want to pay as little, if anything, and your investors want double-digit returns. And by the way, that's all our realities. Whether you're a not-for-profit or for-profit, you have those constituents, right? And if that doesn't work, it falls apart. So we all need to be sensitive to that, number one, which I think leads to my answer to, I hope it's a rapid evolution. And that'll be born of these mini revolutions where we will have the picks and the torches. And those will show up in models like ours, where we come in and kind of poke the system in the eye and say, this can work, where telemedicine can work in certain instances. And it'll advance us, right? And unfortunately, as terrible as the pandemic has been, is it's woken us up to realities of these models can work. And if you don't get on board, you're going to be disintermediated and the system's going to continue. this issue of, consumerism, and forgive me for being a bit of a skeptic, consumerism works if you have accountability. If the payer is not me and that deductible is $50 and not $5,000, where's my accountability on wanting to stay healthy versus relying on the healthcare system to take care of me, right? So you've got all those components. Then you look at our model, we're focused on where the proverbial 80% of the spend is. And hopefully over time, as we get the younger generations to be consumers of healthcare, to be accountable, we'll catch up while we take care of this sort of bolus of spend here. And, obviously being somewhat biased, we've made some incredible impact there. And when you think about the technologies that are there that we've all talked about, we embrace the technology, but it's not a panacea. 40% of my population has cognitive impairment, hearing impairment. That doesn't mean we can't use telehealth. Maybe we send someone in that's not necessarily the provider to help. We affectionately refer to our patients as our Joes and Josephines. Someone's with Josephine, you've got the doctor on the screen, they can do the touchy-feely stuff. And so there are models. I guess to get back to your question, I hope this is an expedited evolution. And that'll be off the backs of these mini revolutions that are happening to jar the system.
Well, you make some great points. I think one of the interesting questions here is, I'm going to go back to the Medicare actuaries, and they'll be a little bit like the maybe the messengers of the fishwives of Paris who are calling for the kings and queens head, because what we're seeing now is, and I'm working on one of our top 10 trends pieces. We're going to do our 10 transformative trends in our next issue of the magazine. And I've been talking to people on the policy side at some of the associations as to what they see happening. And here's something that I know you gentlemen all know, but basically things are getting more expensive, as I mentioned up top. And they're really one of the top advocacy person for one of the associations said to me just a few days ago, there really are only two choices when it comes down to it with continuing rising healthcare costs: severe provider payment cuts, or really pushing the healthcare system into value. And so that individual said to me, I think that there will be even more emphasis in under the new administration and in the new Congress with value, and that they're going to fix some of the problems that have been in MSSP, et cetera, and then kind of really try to get as many organizations in MSSP and next generation as possible. Now, the interesting thing about this is a lot of you are involved in MSSP and also in private payer contracts, and there's a lot of detail around the benchmarks and the rewards and the shared savings. But in Washington, from what I'm hearing, there's going to be a broad bipartisan consensus on where we need to go. So on the value-based contracting and how it might push forward, Dr. LeBenger, you and your colleagues have had such success. What have you found what have been the few absolute critical success factors, and how do you see, what's your perspective on how value-based contracting might move forward on the federal, state, and private levels based on what the pioneers like your organization are learning?
Okay, so a couple things. One, on governmental, I do think they're going to strengthen MA. Okay, and one of the issues is that you can control in MA. You can control a network. Okay, and the direct contracting, even though they could attribute to you, it's a little more difficulty. And we were next gen even before that, but we were always able to save. So what has to happen? There's consolidation in the marketplace, and then there's integration in the marketplace. So when you have a really powerful integrated healthcare model where it's one chart, where you can manage the patient really well, and you can manage the costs down, within it, and you can follow that patient on the gaps care, transitions of care, you could see where you could save a lot more. So I think in the government, they're going to direct contracting. They want to go move to more capitated process, in that, so you can control that marketplace and really tighten it up. On the payer side, I think the claims adjudication is such in the private market that it's going to be very difficult to move to a capitated product across the broad spectrum. I understand there's professional cap and whatever in certain marketplaces within the country, but in the New York metropolitan area, at least, what we do is you have a lot of ASO business, right? Or, self-insured business.
Yeah.
So you really can't go on a cap on that. It's very difficult. It's more of a shared savings. So you have to look at the fully insured business on that side, to move in that realm, but you could still manage the patient really well. So what Nick was saying and what other people were saying, you have to really manage the 10% or maybe even more of the sickest patients and look at the rising risk as you're going. So if you really could cone in, because what do they say? 10% costs 50 or 75% of healthcare costs, whatever it might be. So if you could cone in on that and you look at how you take care of that medical loss ratio and really tighten it up, I think that's how the market's going to drive in the near future on governmental. On the private side, I don't think their systems are up to it. I mean, we did a pilot study over 7 years ago with Horizon Blue Shield Blue Cross in New Jersey, and now we are moving to a fully capitated risk program in their fully insured business. But in the ASO business, it's still going to be a shared savings product, but we're moving to that, in the near future.
Okay, Dr. Solomon, thoughts about that, especially what's working and what's not, where you all pioneers are going to lead us.
Let me tell you a little bit about the evolution that's occurred in California. For our groups, our medical group, we've been in managed care for 35, 40 years. And just maybe a decade ago, 90% of our business was full risk. They give us the cap, we manage the population, and we were at risk for managing the population for both cost and quality. And then because healthcare costs continued to escalate in general, the employers were paying a little bit more, and they got to a point where they said, we want to shift our burden of cost onto our employees, because they couldn't shift the costs for managed care. They started to go to these PPOs, and little by little, they've increased the deductibles for the employees. And the assumption has been that the employees will manage their own care because now they have financial risk. And there's a conflict that occurs between choice and quality. And the assumption for the employer is, I want to give and actually Medicare has the same fallacy. We want people to have choice. They should be able to go and see whoever they want, and then they can find the best doctor. They have no idea how to find the best doctor. And even most, doctors aren't always great at knowing who the best doctor is. You really need to have an overview of people's management of care over time. And so that hasn't worked. Of course, now these employees have this huge deductible that they can't afford, and then they have this co-insurance that they have to pay with their deductible that they just don't come out and seek out care. And so we've seen this shift in this PPO population now more to these at-risk platforms where we collaborate with the employer and they get shared. If we're able to be more cost-effective and hit quality targets, then both of us save. And conversely, if those costs are higher, the health system has to chip in some of those dollars back so that the employer isn't fully on the hook. But one of the interesting things that I've seen is one of the large employers that we have this kind of relationship with, again, they want to have people to have choice. So they've given them a couple of options. So they do have an HMO option, but they have two PPO options. And one is our network, which they call a high performance network, and it's the performance has been better on quality and cost, or they can choose the full network. And that will hit them in both how much they have to contribute, how much is put into their health savings account, and what their deductible is. And typically when we've been in these PPO ACO arrangements, one of the challenges is that the patients get what's called attributed. So we become responsible for this population of patients because they've seen us at some point in the past, and the patients are attributed to us for their risk, of their cost and their quality, but nobody tells the patients because they selected, like, for example, in Medicare and in some of these ACOs through Medicare, the patients don't know that they're in an ACO. And so they don't necessarily get their care from the system. They go out and they get their care elsewhere. So our assumption is, if I have these patients that have selected our system, and I compare them to the patients that are attributed to our system, I'm going to do better on this population. And the funny thing that we found is the opposite. The costs are dramatically higher. They're almost double for the people that are attributed than the people that are designated, that they have selected us. But for our management and our quality, the people that are pick the full pool of providers are more amenable to outreach, more amenable to navigation, more amenable to coming in and getting their quality metrics done. They're actually less cost conscious and more, they want to have that collaboration, and they believe they're getting choice. So they're willing to spend the money to come in and get seen and get care. Whereas the population that's designated, that we have a relationship with, they know they're supposed to stay in our system, they might take our calls, but they are less inclined to come in and spend any money on their care. So we are doing a little bit better on the quality metrics on the attributed than the designated, which is very, very interesting.
Interesting. Thank you, Dr. Solomon. I'm going to throw something at you, Dr. Klasko, but let me first throw out this other element. 3 years ago, I went to World Healthcare Congress, and it was one of the most interesting panels I've ever heard. And it was self-employed large corporations that have these direct contracts with providers. And I'll just mention this example because it came out very strongly. Lowe's Home Improvement, direct contracts with Mayo, Johns Hopkins, Cleveland Clinic. And so they will send, two of those three, I think, and then others had. And in any case, these employers are setting up where if you're going to have a total hip or a total knee, they're going to send you to Mayo. They're going to send you to Hopkins. They're going to send you to Cleveland Clinic. They're just going to tell you, you need a total hip. This is where we're sending you. And they'll even pay for your family to fly with you and stay in a hotel nearby, because this kind of like hyper industrial model, they know that they've saved money because it's a very high volume and they're constantly measuring the outcomes. And so they go to, and they've nationalized, obviously, their approach. So they're sending people from Idaho, to Cleveland Clinic or Hopkins or Mayo. So the reason I mention this is I think it's interesting because everybody's getting into the act in different ways. But I think purchasers, meaning employers, they are getting very impatient with the system and they're wanting to get the highest level of value they can. And I think in certain markets that will really impact people. And certainly it will impact providers in that no longer are you just competing with the hospital or the medical group down the street. You may be competing with organizations 500 or 1,000 miles away. So Dr. Klasko, how does all of that hit you as a very large integrated system in a large city where you do have a couple of dominant managed care payers?
Yeah, for 15 years, we've been hearing that the employers are going to send everything to Cleveland Clinic and Mayo, and there have been some that have done that. The direct-to-employer model, frankly, just hasn't taken hold as much as you might expect in this country. And I think a lot of it is the immense lobbying. It's very similar to pharmacists saying, if you don't pay us retail, we won't be able to do any research. And so, in a place like Philadelphia, Independence Blue Cross, Penn, and Jefferson say, oh, you don't want to do that. That's really bad. I think the key is going to be, I believe, transparency and risk. I mean, so at the point that I can say, I need a hip replacement and I run half marathons, I want to know, Penn, what is my chance of being able to run a half marathon based on your outcomes in a year after my hip replacement? Exactly what will it cost? What do patients say about you, et cetera? And then I can compare that with Jefferson and Cleveland Clinic. And then you get to a model where, okay, Mr. Hagland, for your hip replacement, if you want to go to Jefferson, it's $4,000 of your money. If you're willing to go to Cleveland Clinic because of cost, access, quality, it's $300 of your money. And by the way, there's 2 community hospitals that have just as good outcomes as Jefferson that you can stay in Philadelphia and do it for $1,000. So I think people being willing to take that risk and having real data like they do in other parts of their
Okay.
consumer
Mark,
life.
could
I think in government type of things, I think the big issue is around the social determinants, right? I mean, in Philadelphia, 22% of people don't have broadband. So telehealth was worthless. Online education was worthless until the government's willing to look at connectivity, for example, as a social determinant. Digital technology will not matter.
Yeah. Dr. LeBedger?
Yeah, just to pick up on one topic that Stephen and maybe Adam mentioned about the network. I think that is one place where you're going to see some motion in the marketplace, is that networks will be narrowed to take care of patients or the attributed patients. And I do think that as you move forward, you will see more preferred provider agreements within these networks with maybe hospital institutions or whatever, because the give and take is, if I give you this volume, will you lower my cost structure, right? So there is savings within that to do that. So that's just one aspect where I think you might see some motion, in narrowing a network to manage a patient, but the government doesn't want to do that, right? The government wants to say you can choose whoever you want.
Remember, some of these employers and insurers are still smarting from the 80s and 90s gatekeeper thing that they call economic credentialing. You're not sending me to that place because they're better. You're sending because you're saving money. That might not have been true, but that's a lot of them really got killed based on that old HMO type model.
But
No,
that's
I agree. But when you have, at least in the New York metropolitan area, when you have 4 or 5 major university centers, the quality is not much difference between all of them. And if you could get a preferred provider agreement to lower cost structure, that would make a big difference as you look at the total cost of care.
Dr. Solomon?
I was just going to mention the reason why the employer can afford to pay for the patient to fly to get care at Mayo Clinic along with their family, get put up in a hotel and get evaluated there is because half of those patients that were told that they needed spine surgery locally, once they got evaluated, were told you don't need spine surgery, you just need physical therapy. That's where the savings comes from. It's this overutilization. And as somebody who manages the care of a 250,000 people, I see which are the surgeons in my community that I know. You see this one, you're going to get a multi-level spine surgery. You see this one, you're going to get conservative care. And if you need surgery, you will get the exact surgery you should get if you truly need it. And otherwise, you're going to get managed conservatively just to make sure that that surgery is the last resort and you'll have a good outcome.
But Adam, our American, the thing that's hit me with American consumers is that they're convinced, or many of them, I should say, are convinced that more is better. I hit my head. I have insurance. I want an MRI, because I know you're going to try to do something else, but I want an MRI. Oh, you know what? I went to Mayo and they said I don't need spine surgery, but I still hurt after physical therapy. My friend just went to Mainline and got surgery and is doing much better. I think we get some of that kind of problem too from the consumer angle.
Yeah. So let me, if I can throw in an element here that is underlying a little bit of what we're talking. There's this really interesting dynamic that, I certainly have been watching and observing for a couple decades now. And it's a little bit, it's like a 10-way rumble with kids fighting each other in the park. So here you have, the private health plans, and they want to control their costs. So they're trying to create narrow networks, but then the provider organizations, especially the hospital-based systems, just keep getting bigger and bigger to force contracting so that they can't be let out of a network. And in some markets, in most markets, they've been very successful, because if you're in a mid-sized market with 3 major provider organizations, you really can't leave one out, right, of your network. No one will want that plan, and the health plans know it. So you've got this constant bulking up on the part of the plans versus the providers. And then you've got the dissatisfied purchasers, the employers, who are like, wow, we can't get any control on anything. So I think we're talking about a little bit about consolidation and power, and how these power dynamics play out. Because obviously, in theory, everyone wants the highest quality, but that is disintermediated by the fact that there's so many different market dynamics here that are impacting that. Do you all think that the way things are going in the next couple of years, that that dynamic will change, that we really will get to narrow networks, that will some of these lessons from value-based contracts really will come to fruition, and it will be clear that among 10 big providers in one market, that let's say 5 are really good and 2 are okay and 3 are not so great? Will that become more clear, and will consumers base their decisions on these things, and will purchasers really push the envelope, or will we have more of the same?
Let me give you, if you don't mind, one other story of the local area. The health plans were competing with each other on price, because ultimately the network is broad, because the employers always wanted to have a broad network.
Mhm.
So to lower the price, they would narrow the network down, but not just narrow the network down. The health plan would focus on the cheapest providers, and so they would say, here, we've now lowered your price. You can get this plan for much less than everybody else, and here's your network. And the employers would look at that and say, now you're restricting my employees' choice, and I'm not so sure this is the choice that they really would want to have, so we're not going to take it. So Anthem came up with this idea: let's get the best health systems in our area. So we've got UCLA, Cedars-Sinai, Memorial Care, Huntington Memorial, and so there were 7 different health systems that they brought together, and we developed this product called Vivity. And we all said, we're going to take the risk together on this population, and that will enable us to have a more cost-effective price, because we're sharing information. We don't need to duplicate stuff as much. But because we have UCLA and Cedars in this entity, our costs didn't drop compared to the regular network as much as we were hoping. And so it hasn't quite built out as quickly as we thought it was going to. And there's this, yes, I think they want to have the higher quality known names, but they're not willing to pay for it. And they still have this background of wanting to have their choice, thinking that they can tell who they want to go see because their website is the best, or their neighbor had surgery there and says that they're fantastic.
Yeah, that's exactly the web of tensions I was talking about, Dr. Solomon. You can't have everything. You can't have unlimited choice, the very highest quality, lowest cost. It's like 5 different things that can't all be true at once. So we have a couple questions. So let me they're good questions. So let me pose them to our panel. First of all, this is a little shorter question, I think, to answer. Do you see networks emerging for the provision of care for specific populations, i.e. respiratory, pulmonary, pulmonology? Do you, who would like to leap in on that?
Yeah, I think I think we talked about that a little bit. I think where we're starting in those kind of things is with the highest cost and most medically unnecessary procedures. So, you mentioned spine, Adam, and I think, that's one of those examples where there's so much more spinal surgery that needs to be done at such a huge variability of cost. I can tell you a personal story. In 2001, I was doing surgery, I had some tingling in my head. I had 4 surgeons tell me that I would, be paralyzed if I didn't have surgery. And I've run 5 marathons since then and never had the surgery. It's a crazy area with huge expense pieces. So I'm not sure it'll be as much in respiratory and pulmonary and pulmonology, only because those things are so interrelated with other things. If I have COPD, I might have CHF and that kind of thing. But specific things like hip replacements and knee replacements and a lot of orthopedic things, dermatologic procedures that are just so expensive, so variable, and so overutilized, I think you will start to see more and more, both locally and, as we've talked about, nationally. In some cases, internationally. We didn't talk about necessarily medical tourism, but there's some of that going on also.
Okay.
Ironically, I want to go back to something Dr. Klasko said earlier. I think if we could come up with a system where we incentivized our primary care providers to play that quarterback role, do more of the education, stay closer, spend more quality time with their patients. So not having 2,500 patients on their panel, maybe having 500, and I'm just making up the numbers, we get there, right? And I, Dr. Klasko, I've had similar experiences to yours. I have a lot of, provider friends that if I mention an ailment, I've got 6 doctors I should go see, right? And we become this system. I go back to what I said earlier on the accountability side. If you're not paying for it, and believe me, I mentioned earlier, I'm Canadian. I come from a system where, people say, yeah, the government pays for everything. I'll tell you how they control cost: access to certain therapies. Yep. You can show up at your doctor and ask for something and just tell you we don't have it, right? And that's it.
And global budget.
It's interesting, as opposed to going more narrow. I think we can, if we go more upstream, we focus on health and prevention includes procedures. And I'm not saying everything's elective, but I do think we should be focused more on that than going, upstream.
Mark, so I don't want to spend much time on this, but what you're going to see, and I think what the government's going to try to foster, is to move more to the ambulatory sector, away from the high cost areas, right? Like surgeries or what might be in a hospital system, right? So what we have seen, okay, and we've always, it's interesting, the old QRUR report, we used to save 20%, of course, year over year over year, but our costs on the ambulatory side were so high, but on the inpatient side was so low because we prevented the admission into the hospital or maybe the surgery. So if you have a really good integrated ambulatory network of physicians, it doesn't matter how many times you see that ambulatory network of surgeons, okay? If it's the right quality and you will manage that patient out of the higher cost area or surgery, what you might want to do and manage that. Just for instance, CHF. All you have to do, we had 500 CHF admissions, last year, or you'd manage 10%, $20,000 per admission. Just think what that is. So when you build up the right data analytics in the model, that you could do an algorithm and manage that and keep them out of the hospital and move it to the ambulatory sector, I think in the next few years, that's what you're going to see. You're going to see more control of the network, controlling that patient out of the high cost areas. And that's one of the areas.
But Jeff and Nick, I think, look, you have to follow the money. And Nick, to your point, I remember when we started our ACO and our MSSP, I went to my family community medicine department. I said, good news, you're going to be the quarterback for the system. And they said, well, thanks so much, but you pay me like the kicker. You pay your neurosurgeon, your orthopedist and dermatologist like the quarterback. You want me to be the quarterback, be the quarterback. When I was in Florida, we had started a primary care driven system with the villages, which is 150,000 seniors, where literally the specialists in the hospital were the deep end variable, like some of your systems. And it totally changed things because these folks were able to get paid for doing the right things. And family docs were making probably twice what my family docs made. And the private orthopedists weren't doing as many spinal procedures, and patients were healthier.
Yeah. Correct. Okay. Correct. But just to add one thing, I'm sorry. You're right. You keep the number of specialists down to make them happy. I'm a surgeon, right? So they want to work by the widget. But with the primary care, we bonus them a lot of dollars to be able to drive metrics and behavior in their organization. And it does come down to compensation. You're right, Stephen.
Okay. So
incentive drives behavior. That's
right. Exactly.
Absolutely. Always does.
So we have one more audience question, and I want to allow time for a summation from everyone. So I'm going to ask that this be a jump ball and just have one person answer, just because I want to give all of you a chance to sum up. So the question is relevant to the discussion on cost and overutilization. Why has there been a lack of implementation of medical necessity and coverage of benefits, both in quotes, for Medicare/Medicaid uniformity as compared to commercial payers? Anyone want to tackle that one? It's a little bit complicated.
I might take a stab at it. So there is medical necessity. Medicare has a whole series of national decisions on when different services are medically necessary. The thing is, Medicare doesn't look at anything unless they audit later on, and they don't audit that much. And in MA, they're capitated. They give the money to the health plan, which may or may not then give it to the provider organization. And now they're responsible, and they'll use those guidelines to determine medical necessity or not. The issue is medicine isn't black and white. And if you've got a patient who has symptoms and you've got a surgeon that knows how to document, it becomes very hard to deny. And the health plans are loath to uphold a denial, because then they're going to get appealed to the federal government, who's always going to go in favor of the patient. The patient says, I need this procedure. They're going to get the procedure. So some of that management is a huge challenge. And that's where getting back to using that network that you know is going to simply manage the patients well is the best way to go to get the outcomes.
Okay. Well, and I just uncovered 2 more questions, so we're gonna try to answer them really quickly and still allow a couple minutes for everyone to sum up. This one is for Dr. Klasko specifically. Dr. Klasko, I just started your book, so I'm curious as to what 2 or 3 initial technologies are shifting the paradigm to more technology/service-based health assurance.
Yes, I'll just answer this real quickly. We wrote a book with Heyman Taneja, who was the initial investor in Airbnb and Livongo and Warby Parker. And it starts out, so what if a Silicon Valley entrepreneur and the CEO of a 195-year-old academic medical center walked into a bar, got married, and had a baby? What would that look like, marrying those 2 together? So I think the 3 that I would say is, one is digital technology that'll really start to address gaps in healthcare. Things like City Block that have started to look at how can we keep healthcare at home for the most underserved. I think wearables that allow us to send continuous data instead of relying on a once-a-year physical. That's been one of our most successful partnerships so far. And then third is what we talked about before, digital ways of really providing real transparency, patients being able to compare providers, costs, access, and user experience as they can in every other part of their consumer lives.
Okay, great. And very briefly, someone asks, my health system is attempting to prioritize the many digital/virtual health opportunities and align them with our strategic plan. What's a good first step to create a shared vision? And I hate to say it, but I'm going to give one person 1 minute to answer that. And I know you can't really. Anyone have a quick thought on that?
Well, so what I believe is we have to get away from the HIMSS mentality of walking into a place where there's 970 24-year-olds telling me how they're going to transform healthcare with their digital app. And what we've done at Jefferson is we've created a whole strategic partnerships group that says, which of these things can actually help us achieve our strategic goals? And then we want to be part of that. I don't want to have ever again somebody say, hey, I couldn't have done our billion-dollar company without you. I want to take you out to dinner without my being part of it.
Right. Okay, good. All right. We have a few minutes left. Each person literally gets 1 minute, but I want to give you all 1 minute. Any last thing that you would like to say to our audience? It can be advice or a prediction or just a summation. Let me just go in order. Dr. Klasko first.
So 2 quick quotes. One is from Upton Sinclair. It's hard to get somebody to do something when their salary depends upon them not doing it. That's been a big problem in healthcare for a long time. We talked a lot about that. And the second is actually from Jason Kidd. When he went to the Dallas Mavericks in the NBA, they were 24 and 52. He said, we're going to turn this team around 360 degrees. We do a lot of turning things around 360 degrees in healthcare. And I think the real question post-pandemic will be, is that really a major change, or are we just going to claw back to what makes me money as a hospital system, what makes the payer money as a payer?
Very good. Thank you. Dr. LaBencher, you get 1 minute.
Yeah, I don't think that you're going to see large tectonic shifts in healthcare, okay, over the next few years. I do think that the government is going to try to move more towards capitation, like direct contracting, and move in that direction. And payers are going to look at more sharing costs with their employer-based as well as the providers, as you move forward in the organization, and they're going to move more towards shared savings and quality and value within this world of healthcare.
Thank you so much. Dr. Solomon, a quick minute.
Sure, I agree. I think it is going to be an incremental change. We have so many entrenched interests in maintaining the status quo that we'll see this sub-fragmentation, but at some point it will start to come together. And the saying is that things will be slow until they're fast. It reminds me somewhat of that scene in Monty Python and the Holy Grail where they're standing at the doorway, the guys come in to attack, and they see him way in the distance, and he's running towards them, and they're just eating an apple waiting because it's got a long way to go. And then you see him, and he's coming, and he's got a long way to go, and they're waiting, and he's so far away. And then all of a sudden he's there, and he kills them, and he goes inside and plays. It's just going to be, it's going to be coming, it's going to be coming, it's going to be coming. And then all of a sudden, people realize, wow, things have really changed.
It's there. Great, thank you. And Nick Lopacaro.
So I'm going to close where you started, Mark. We know where the puck's going. We can turn a blind eye and pretend it's not going there. And whether it's the models, Jeffrey expanded on, and they may be different in a couple of years, but there's going to be some form of value-based, risk-based, risk-sharing, including the patient and the consumer. And I would encourage everybody to continue to pursue that, not be afraid of it, embrace it, because it's, to Adam's point, Dr. Solomon's point, if you don't, you're going to be disintermediated. It's going to happen. Like whether you think it's going to happen or not, it's going to. And you're going to wake up one morning and go, boy, that happened pretty quick. And it was a 20-year evolution.
Right, exactly. And we didn't even get a chance to talk about that whole subject, but yes, there will be some disintermediation, and some of the disruptors will come in very quickly. So I'm just going to quote the Roman orator Seneca, who didn't know the Medicare actuaries, but might have if he had, for this quote. Seneca said, the fates guide those willing to change, those unwilling they drag. And I just hope that everyone will be among those willing to change and not be dragged, because that's very painful. So thanks to our pioneers here on this panel, because you're all doing it. You're moving toward the future, and we appreciate you so much. And Stephen has magically reappeared to close us out. So thank you, gentlemen.
Thank you.
Yes, I am back. Thank you all very much. That was a wonderful conversation, greatly insightful to the attendees, and I think we all learned quite a few things, so we appreciate it. Just one quick housekeeping remark. Dr. Klasko has a couple of books that I don't think we got to mention, but I did want to point out that we put a link to them on the resources list, which is on the virtual events page where you guys access the session. So check that out there. Don't forget to join us again at 11 a.m. Eastern for our conversation on telehealth. We also have a data conversation happening today at 2 p.m. Eastern, and we're rounding out the day with a remote monitoring home health trends session. So looking forward to all the great sessions coming up today. Thank you all for joining us for the very first session of the 2021 Digital Virtual Health Series. Thank you again to all of our panelists. And this concludes our session. I'm going to go ahead and disconnect us now. We'll see you.
Thank you. Be safe, everybody.
Thank you.
Bye-bye. Be well.
Take care, everybody. Bye-bye.